Thanks, Damien. Welcome, everyone. We're very excited to be here today and wish to thank all the speakers and all the attendees. We have a large number registered to attend of multidisciplinary professions. So this is the first series of Building Perinatal Network webinar, which we are running. Next slide, please. The webinar will provide us an opportunity to hear more about the concepts of the perinatal teams and the importance of multidisciplinary collaboration in improving outcomes. We want to learn from highly successful perinatal teams, as we hear from the PERIPrem project team, and want to explore the exciting new preterm perinatal wellbeing package resource. Next slide, please. So this is the word cloud of all the attendees who have registered today, and this is the first time we have had such a wide range of multi-professionals who have attended, and the concept of these webinars is that we would like to build perinatal teams going forwards where we collaborate and work together. Next slide, please. So without much ado, I would like to introduce Dr. Julie-Clare Becher. As you all know, Dr. Becher is a consultant neonatologist at NHS Lothian, and she is also the quality lead at a British Association of Perinatal Medicine till 2021, and she has co-chaired the development of BAPM Perinatal Optimization Pathway Quality Toolkits. So Dr. Becher is going to talk to us about building a perinatal team to support preterm optimization. Over to you, Julie-Clare.
Thank you very much, Nirmala. Can you see my first slide?
Yes, thanks.
So thank you very much for inviting me today to speak about building successful perinatal optimization teams, and that's specifically around improving team culture and the quality context around the interventions that we know are important in improving preterm outcomes. And as you know already, the BAPM has been really instrumental in developing a set of quality toolkits which support the delivery of evidence-based interventions to improve preterm outcomes. And this pathway, the perinatal optimization care pathway, was really based on the fantastic work that MCQIC did back in 2015-16 in developing the perinatal wellbeing package. But delivery of these elements and delivery of the quality improvement projects can only really take place successfully if we have a very good perinatal team culture, as well as a good and robust quality context. And that's what I really want to talk about today. So there's an increasing imperative really throughout the UK, increasing number of drivers for improving culture and context. And I want to highlight particularly at the top of this diagram, the SPSP MCQIC Essentials for Safe Care programme, which is a fantastic work stream that's really all about improving safety, improving culture and building teams. And it's an excellent piece of work that I encourage you all to look at and engage with, because it has developed a lot of the same principles that we have taken on within the BAPM toolkit. But in addition to that, we've got Maternity and Neonatal Safety Improvement Programme down in England, the Care Quality Commission, lots of documents and reports from NHS England, and the British Association of Perinatal Medicine also has, headed by Gopi Menon, developed the Neonatal Services Quality Indicators back in 2015, which was a fantastic piece of work really describing what a good quality context looked like. And that is now embedded in the BAPM Neonatal Service Standards. But I want to draw your attention to the inquiries that have been reported over the last 7 or 8 years from Morecambe Bay, East Kent and Shrewsbury and Telford. And these, while these sit about 8 years apart from Bill Kirkup's report of Morecambe Bay back in 2015 through to the Ockenden report and his second Kirkup report, the second Kirkup report for East Kent that were published this year, The recommendations really are almost the same throughout all three documents. The recommendations are that we should be listening to patients more and parents more, being compassionate and ensuring shared decision making, improving the standard of investigations, but not just doing the investigations on their own, making sure that we have organisational memory with implementation of action plans, really trying to establish good, solid clinical leadership and leadership in patient safety and quality, training across teams that involves the multidisciplinary team and throughout networks, and fostering skill thereby in managing complexity in care pathways and risk assessment. And crucially, this key factor here at the bottom about optimizing team working so that we can really stop this silo working that happens amongst our professions, the tribalism that can happen, and the poor behaviors as well. And while these recommendations apply to these three organizations, really tellingly back in 2015, Bill Kirkup had written, "It is vital that the lessons, now plain to see, are learnt and acted upon, not least by other trusts, which must not believe that it could not happen here. If those lessons are not acted upon, we are destined sooner or later to add again to the roll of names." And it's easy to sit here and think, well, these trusts, these recommendations don't apply to us. They happened in other areas. But I think we'll see as we go on that there are elements of culture and context that we can all improve on. And that is supported really by the Care Quality Commission, whose role it is to establish or assess the quality of care in trust with NHS England. And here you see the maternity core service ratings for NHS England maternity services compared between July 2021 in the pale colour and July 2022 in the dark colour. And what you can see here is that around 38% of trusts in 2022 were either deemed inadequate or require improvement. Sorry, not trusts, but maternity services. And that this has got greater over the last 12 months, so that we're not going in the correct direction. And while you might argue that this applies to maternity services, we can see from the inquiries that were undertaken over the last 8 years that there is a real need for neonatal services as well to be examining their context and culture as well. So what do we mean by culture? So culture is defined as the beliefs, the attitudes and assumptions of the members of the team that result in normalised and shared ways of thinking and working and practicing and behaving. And it becomes the way that people think around here and the way that things are done around here. But when we think about trying to change culture, it immediately kind of slips out of our grasp. It becomes a sort of intangible and nebulous concept, which is very complex. It's sort of multifactorial. It's often deeply ingrained and has been for years, sometimes decades, and it exists at multi-levels within different professional bodies and across different teams. And when we think about trying to change it, it's not something that's ever going to be a quick fix. It's slow to change. It's hard to change, and you've got to be in it for the long haul for sure. And then we're going to talk about perinatal optimisation culture, which has a whole other layer of complexity. And I'm talking about everything that leads up into preterm birth and then the 24 hours after that. And what we have is multiple interrelated sub-teams that are looking after not just one patient, but two, so the care of the woman and her baby, who are often undergoing prolonged episodes of care that actually may have started even before pregnancy began. And these pathways are very often complex because of the nature of preterm birth and maternal morbidity and risk factors. The care often takes part in different departmental locations as well as different geographical locations. And I want to talk a little bit about how context and culture actually is really important in one of the perinatal optimisation interventions, and that's deferred cord clamping, or what we call it the BEPM, optimal cord management. And I've often heard it said over the last 2 or 3 years from units or services where they may have lower rates of optimal cord management than would be expected or than desired. And I've heard people talk a lot about, oh, I'm just going to, we've got the kit on order, or we've applied to our management team so that we can invest in a couple of these trolleys that will help us do cord clamping, and that's going to get our rates up. But I want to argue with you here that it's not about the kit. It's actually about the culture. And this is really true of optimal cord management, but it's also true, very true of other interventions on the perinatal optimization pathway, such as place of birth and also maternal breast milk, kind of complex interventions that involve various different teams. It's about us working together and alongside each other, different professional teams standing side by side, supporting our colleagues and having shared goals around preterm birth and developing pathways to make that happen. And in doing so, we understand better all of the optimization interventions and why they are important. And that leads to us then looking at the data together, so determining what the barriers are, what the facilitators are, and celebrating success together. And so it's not just about the kit, but if we can get the culture right, as we have done in the Simpson here in Edinburgh, we don't have any trolley. We stand side by side with our obstetric and midwifery colleagues during optimal cord clamping, and we have a very high rate, which is the median of 100%, without any need for any other sort of stabilization equipment. So this is what we're trying to drill down on during this lecture and this webinar, is about the culture and the context in which we undertake many of these important interventions. When we talk about the quality context, that is very related to culture, but is slightly different. It is the readiness for change that exists within our organisations. And I want to illustrate this using another perinatal optimisation intervention, and that's achieving normothermia on admission for preterm births. And so, for example, we have Unit A who have a problem with hypothermia. And so what they do is they download the BAPM normothermia toolkit, and they decide after a process mapping and consultation with staff that plastic wraps is the thing that they need to be undertaking to make their babies warmer. And what they find is that they find an 80% reduction in admission hypothermia over time. So they quite rightly feel like celebrating their success. They submit their abstract to the BAPM scientific conference, and there, a junior doctor from Unit B hears of this and they think, wow, that's a brilliant idea. I'm going to start doing plastic wraps as well. And so they take it back to their unit and they find no reduction in hypothermia. Why is this? Well, it all boils down to context. If we look at what happened in Unit A. So what happened in Unit A is that quality improvement team was organised with members of all of the multidisciplinary team. They discussed the interventions and the process mapped, the process from birth onwards to achieve normothermia. They developed shared goals as a team. They rehearsed the intervention during sim training, and they established pre-briefs before every single preterm birth where thermal care was recognised and a member of the team was allocated to thermal care. And what they did is they had regular staff feedback, looking at where there were opportunities for improvement, but also celebrating success. Instead, in Unit B, this was a 3-month junior neonatal doctor project that was led by a consultant with no QI training. There was no engagement of the team, and it took place in a labour ward which was undergoing a refurb and was very drafty. And you can see there how context is so very important in understanding why your intervention may or may not be working. Can you have one without the other? What is the relationship between culture and or context? Well, here are some examples of where a good culture might exist without a good quality context. And that might be where you've got a great team working between the different specialities involved in preterm birth, but there's no training in QI, so there's no real understanding about how the change ideas might actually get into practice, become embedded within the context. There may be enthusiasm for change, but without data or without the right person to collect that data. You might have really good risk reviews to look at the root causes of serious adverse events or mortality, but the people who are doing these are unsupported without allocated job plan time. Or you might have perinatal optimisation guidelines, which are in place across all of the network, but they differ between different sites within the network, so that it means that women going between different sites may experience different experiences of their care. Whereas you might have a really good quality context, but without good culture. So this exists where you put in place elements that tick the box, for example, safety huddles or risk reviews or perinatal mortality meetings, but that the culture is not good to facilitate change. So there might be risk review meetings which focus on blame or individual responsibility rather than systems. It might be about safety huddles that don't include everybody, that don't include everybody's voice, where people's ideas are dismissed. It might be a perinatal mortality meeting where half the team doesn't turn up, or they turn up late, or it goes on half an hour later than it should do. It might be about having quality leads, particularly within the trust, who are out of touch with your frontline pressures, or holding simulation programs that don't involve midwives, that don't involve neonatal nurses. So I'm hoping I'm starting to win you over a little bit about how important it is to actually have culture and a good context as a strong foundation for any quality improvement projects that you want to undertake. But you're thinking to yourself, crikey, we've already got these 4 documents, these 4 toolkits, and now you're telling us we need to grapple with this very difficult and complex problems such as context and culture. And what is the evidence in perinatal optimisation in particular? Well, there's a wealth of evidence which is coming forth now, and there's a lot more than this contained in the toolkits. And then if you want to explore this further, each of the toolkits has their own list of references that support why it's so important to deal with culture and context alongside your interventions. And there's a lot of interest now about where you put in place interventions to improve your culture and context, that you actually end up with much greater success with these various measures, including place of birth, magnesium, steroids, and indeed preterm outcomes. So what we have done at the BAPM is helped you as clinicians understand best how to address team culture and quality context. And this is a resource to support the toolkits that are already there. And we've collaborated with the Maternity and Neonatal Safety Improvement Programme in delivering this. And we have representation from parents and members of the wider perinatal team. But importantly, these are around the perinatal optimisation interventions only, so really take you up until the first 24 hours after birth. And we've got some fantastic support and advice that we've had from HSIB and the Neonatal Transport Group and PERIPrem also. And the first part of this section of this resource is really about how to assess your context and culture. And that we encourage teams to look at a wide range of information that they may get from staff culture surveys, from parents, feedbacks and trainees, parents, families and trainees, looking at your performance in perinatal optimisation, looking at the barriers that exist there. There may be data from external reviews or from other mechanisms such as themes from SAEs, etc. And to use this data from a wide range of sources to really gather intelligence about what the culture looks like and what areas in that require development, require strengthening, and what you can learn from where your culture is going well. And section 2 is really about implementing improvements. And we do this under 6 main headings. There's leadership, there's person-centered pathways of care, there's a section on team working and positive communication, another section on risk, but also learning from safety 1, but also safety 2, so excellence as well. There's a section on why data is so important, and that includes research data as well. And lastly, and not least, the establishing capability and capacity for quality improvement, which is so important in delivering any kind of change. And each of these sections have activities that we suggest that you might undertake as a team, and we signpost very frequently to the Essentials for Safe Care that has been developed by the SPSP. Again, a fantastic set of resources there that can be found on the NES website, I think, as well. We suggest some solutions that are not prescriptive at all, but that we encourage you to find your own solutions with some suggestions from us and some improvement stories as well. So when I talk about the activities here, these might be about constructing relationship diagrams about your teams and how they sit. What can we learn from the strong relationships in the team that we can take into those that are less strong and that need some development or that indeed may be stressful. There are many online resources such as TED Talks about psychological safety, about how to build teams, what does social capacity mean and what does that look like. Bits about understanding person-centered care, so vignettes that you can follow through as a multidisciplinary team and work out how best you might tackle that as a team. And obviously the safety culture discussion cards, which have been developed by Ness as well. In terms of solutions, that might be about helping teams foster shared goals and what that might look like around preterm birth. There are suggestions about how you might establish a model to enhance trust engagement in preterm optimisation, how you might communicate with parents around perinatal optimisation, or developing a perinatal team approach, a sort of holistic approach to counselling. There are also some appendices, most notably about behaviours that you might want to encourage in multidisciplinary team meetings, as well as a suggested sort of suite of perinatal optimisation guidelines to standardise across the network. I think a really key strength of the resource is the improvement stories that you as a perinatal community have sent in to us about your work around perinatal optimisation and how you've developed important work streams in improving culture. And I really encourage you to go to the resource and click on these. It's really been fascinating to hear how teams have addressed these, what barriers they've met and how they've made it good over time, or how they are making it good over time. So the resource has the consultation period has just finished. There will be a period of us responding to the feedback, but we're hoping that publication will happen either later on this month or at least very early in the new year. So look forward to discussing any of your feedback or comment later on in the programme today. Thank you.
Thanks a lot, Julie-Clare. That was an absolutely excellent presentation, very enlightening about all the work that's been happening behind the scenes. And you have set the scene for our webinar and for our series, really, of building perinatal teams and the importance of building teams and highlighting the importance of culture and context and optimize and how we can use that to optimize perinatal outcomes. So thanks a lot. We will have questions if you have for Dr. Becher at the common question and answer session after the next few presentations. So next, I would like to welcome Dr. Sarah Bates. She is the Neonatal Operational Clinical Lead and leading the PERIPrem work. And she is also the clinical lead and quality lead for BAPM. We also have Aless, who is the neonatal QI fellow from PERIPrem team, and recording from Dr. Tracey Kay, who unfortunately couldn't be present live with us. She is a consultant obstetrician in the PERIPrem team at Royal Devon Hospital. Thank you, Sarah.
Oh, thank you so much, Nirmala, for that kind introduction. Aless and I are honoured to join you today. And Tracey would have been honoured to join you too, but she's had a very short notice CQC inspection to prepare for. So, but she has shared a recording with us because we felt it was really vital to come to you today as some of the core members of a perinatal team to talk to you about PERIPrem, which we have run across the southwest of England for the last 2 years now. And much as Julie-Clare said, really, Much as the BAPM work on optimisation was inspired by MCQIC and by your perinatal wellbeing package, there's absolutely no doubt that PERIPrem was inspired by that too. I was watching the work happening across Scotland in 2015 and 2016 and started a similar project in my own small unit in Swindon in 2017. And then that was taken forward by the academic health sciences networks across our region in conjunction with a project from Bristol, and PERIPrem was born. So it really is a massive honour for Aless and I to be here today, because very much the inspiration was taken from all of the work that was done in Scotland on this. So we're going to start by hearing from Tracey, who has led PERIPrem both in their own hospital in Exeter, but also has been the obstetric lead for PERIPrem and now is the obstetric quality lead for BAPM. So I will hand you over to Tracey's presentation.
I'd like to start with an apology for not being with you in person today. Unfortunately, CQC have sprung on a visit to our unit, and I felt that I should be with my perinatal team to support them today. I'd also like to just thank the team for giving me the opportunity to just give a very brief view in respect to an obstetrician from a perinatal optimisation point of view. So you could argue that as an obstetrician, once I have delivered the baby, I have passed the responsibility over to my neonatal team and then on to the care of the health visitors, primary care, etc. But obviously, as an obstetrician, my job is to ensure that I deliver that baby in the best condition, and therefore I need to optimise their condition. And to do that, I need to work together with my perinatal team. Those babies, we hope, will grow up into children who can run around like all other babies that are not born premature, and then go on to be our mothers or fathers of the future. So you will already heard about the PERIPrem project and the 11 bundle elements. I was very privileged to be an obstetrician in Exeter and working alongside Sarah and the rest of the team on the perinatal PERIPrem project, and was very excited about this, particularly as it launched during the pandemic and gave me something other than COVID to focus on. When you look at the bundle elements, you could easily break them down into the first 7 being very specifically obstetric or maternity driven. The 4 at the bottom there are specifically related to neonatology, and there are some that cross over between both maternity obstetrics and neonates. But I would argue that we have a rainbow effect, and ultimately we are working as a perinatal team to ensure that all of these bundle elements are given to each and every one of our preterm babies. And our neonatologists who visit our women either on the antenatal ward or when they're on labour ward in preterm labour will talk about many of the bundle elements that in fact we as obstetricians prescribe, so antibiotics, magnesium, steroids, for example. And also us as obstetricians will talk about how we're going to keep the baby warm and how we're going to manage the cord optimally. And although I don't know the ins and outs of caffeine and probiotics as an obstetrician, I have been known to ring our neonatal unit or walk over just to check that our extreme preterm babies have received their prophylactic hydrocortisone within the first 24 hours, because I'm very aware of all of the bundle elements that come with the PERIPrem passport. So it's not the neonatologists working on one side of the rail track and the obstetricians and maternity team working on the other side. we're actually all working together to ensure that we make sure that that baby is born in the best way and in the best condition. So we're working together and singing from the same hymn sheet. And in our unit, PERIPrem is a verb, so each baby gets PERIPremmed. We all use the term PERIPrem, we all use the same passport, and we are all singing from that hymn sheet. Now, I was asked just to give a couple of minutes view in one of the aspects of the PERIPrem project that we drove in our unit. So we are a level 2 unit, so look after babies above 27 weeks. And in 2019, when you look back at our stats, only sort of less than 50% of our babies received optimal cord management. And I was unaware that the importance of this, and I had at the beginning of this project no idea on how I was going to push through with this. But I was very enthusiastic and I really wanted to make a difference, particularly when I heard that waiting 60 seconds to clamp a baby's cord can reduce its mortality by a third. I mean, that stat just blew me away, and I wanted to make a difference. So I needed to work together with my team, and that wasn't just one neonatologist, one neonatal nurse and one midwife. It was actually the whole of the unit. It was every obstetrician, every neonatologist, every neonatal nurse, every midwife, the theatre staff, the ODPs and the anaesthetists. Everyone needed to work together to strive to improve this. So to do that, they needed to know the importance, and we needed to share that with the teams, and we did this through education, through posters, through T-trolley training, and just making sure that the message went out there to everybody. We walked through sims, we produced diagrams of where certain equipment should sit, we produced a SOP, and we really just got some very basic pieces of equipment. So we use a plastic T-trolley with a transwarmer on it covered in a sterile drape onto our mum's legs, and that acts as a support and somewhere warm to keep the baby. You don't necessarily need an expensive alongside resuscitator, and we use Neo help bags to keep our babies warm. And after we'd walked through our sim and written our SOP, we ensured that we shared that with all of our teams, including videos and training regularly. And really, it was just positive feedback to people. If they managed to achieve this, it was fantastic. If things didn't go quite to plan, we talked through how we can improve it. And it was really exciting. This is a picture from a video that we did of a 29-weeker right at the beginning of our optimal cord management journey. And there is me. We have a neonatal nurse, a neonatal doctor, the scrub nurse and an assistant. And this baby achieved 2 minutes of optimal cord management. And what we've managed to achieve as a unit is in the last year, 96% of our babies received optimal cord management. And for me, when you look at the numbers needed to treat, we have to wait 60 seconds for 20 babies to save 1 life. That means in Exeter, we've saved at least 1 life. I'm sure we've saved more. And I couldn't have done that without a fantastic group of individuals, all striving to ensure that our smallest and most vulnerable babies are born in the best condition that we can give them. Thank you.
That's fantastic to hear Tracey talk. I've heard her talk on this topic a lot, and it never fails to be absolutely inspirational. And I think some of the things that I was just noting while Tracey was talking really echo some of the things that JC talked about in the new toolkit. It isn't necessarily about kit, it's about the team, and it's about the whole team. And The team working across the entire region in the Southwest for PERIPrem has been wonderful, and we're hoping to share a little bit of that with you now. But I can see from the attendee names that we have some of our PERIPrem team members joining the call today, and these are neonatal nurses from small special care units who have been such dynamic and enthusiastic leaders. And that's one of the things that Tracey mentioned on her slides, was about the importance of enthusiastic leadership. So Aless and I are just going to take you through a few of the things that have really helped us to deliver PERIPrem. We're going to talk a little bit about the background about PERIPrem, and then you'll hear from some of the parents that have been through PERIPrem. Next slide, please. So I think trying to understand the concept of the perinatal team is really crucial, and certainly the new resource that JC has led is really great at helping us think about that, because the content of that team might change in different centres, it might change at different points in the journey, but undoubtedly the importance of multidisciplinary collaboration can never ever be underestimated. And one of the things that was so hugely successful for the implementation of PERIPrem was the model of delivery, which was having a neonatologist, an obstetrician, a neonatal nurse and a midwife in every single unit. So this wasn't delivered by one regionally employed network fellow. This was delivered by people on the ground at the front line, who could really have a great understanding of their own context in their own unit, and had the buy-in and the support from their own team to be able to drive change. Next slide, please. So I'm just going to talk briefly about what is PERIPrem and why it came about. And Aless will really talk about the how. What were the barriers and the enablers? And one of the crucial elements for PERIPrem was the inclusion of parents as part of the steering group. Next slide, please. So within NHS England, we have the NHS long-term plan. And because our rates within the UK of infant mortality are relatively high compared to the rest of Western Europe, and also they were not falling at the rate that we wanted, we have the NHS long-term plan. Now, it's got really ambitious targets to reduce the rate of neonatal brain injury and death. We didn't quite meet that target in 2020, and for most regions, we're not on track for 2025. And the vast majority of that newborn brain injury and death is, of course, in the preterm population. Over 2/3 of infant mortality within the first year of life is in babies born preterm. Next slide. So, as I mentioned, really inspired by the perinatal wellbeing package in Scotland, in Swindon in 2017, we launched a programme of perinatal optimisation interventions. Professor Karen Lloyd, who is my co-lead for PERIPrem, had run the incredibly successful regional and then national across England precept programme for magnesium. She'd been working on a wider package of interventions. Those two were merged, and with the support of both academic health sciences networks and our regional neonatal ODN in the Southwest, PERIPrem was born. Next slide, please. So this is the Southwest. We have some interesting geography, perhaps not quite as challenging as Scotland, but certainly some really large travel times between some of our centres. We have around 8% of births in England are in the Southwest, and we have 12 centres, 3 NICUs, 3 special care units and 6 LNUs. Next slide, please. So we brought together a steering group of perinatal team representatives, and I have to give huge credit to the work done by Aless as the QI fellow. She has been so fantastic in driving forward a lot of the resources that have been so highly valued by the teams. The parents were incredibly powerful in co-design, and we will show you the baby passport that they really led on later. We provided funding into every single one of the units, so special cares, LNUs and NICUs, to recruit a midwife and a neonatal nurse and to give them backfill funded hours over the implementation phase. Now the quad teams, so that's the obstetrician and the neonatologist who don't have funded hours, and the midwife and the nurse, are all still in place in the centres, and we all still meet, even though the implementation phase ended a while back. Next slide, please. So this is the 12 bundle elements, and you can see here the resources that we have. And one of the things that's really powerful is, as Tracey touched on, that universal language of PERIPrem across our whole region. So women moving between centres and between different levels of service are hearing the same language. They're seeing the same resources. Our obstetric and neonatal trainees that move around the region suddenly know what optimisation is all about. It's not called something differently. It doesn't use different resources. And also it meant that teams who wanted to work on these elements didn't have to suddenly make their own new poster or do their own literature search. They could just pull these off of our website, and all of the resources are endorsed by the Neonatal Nurses Association. Next slide, please. So I touched upon the massive importance of parental co-design, and these were parents with lived experience of preterm birth. And we started to make the clinical passport, which has been hugely useful. And they said, well, hang on a sec, we think the parents need a version of that, because we want to make sure that the parents understand these elements. And in some cases, parents can be a powerful improvement partner, a powerful driver for change, if they're empowered to know the interventions their baby should be getting and why. So the way that this works, alongside our clinical passport, if I tell you how it works in my own unit, it's pretty similar across the 12 units, slightly different for those that have electronic systems well set up. But let's say a woman arrives on my unit at less than 34 weeks gestation and she's at risk of delivery. There's a PERIPrem box on the unit, a big plastic box with lots of resources in. And in there is the clinical passport, which helps us understand what interventions to give and track the timing of those interventions. There's the baby passport. There's an expressing breast milk leaflet and some resources. And that then all goes to the woman. And she might then go to the antenatal ward. She might progress on and deliver. If she does, then the interventions continue to be tracked on there, and the passport moves, the clinical passport moves through with the baby to the neonatal unit and becomes a brilliant source for the junior doctor or ANNP that's putting that baby onto the Badgernet system. And the parent keeps hold of the baby passport. Next slide, please. So looking through some of the interventions, and I will hand over to Aless shortly to talk about some of the qualitative elements. I just wanted to talk about the quantitative impact of PERIPrem. Next slide, please. This is published in this article, and I will put a link in the chat shortly. Next slide. So apologies if the text is really small on your screen, but just to summarise that pre-implementation through to the post-implementation period, we saw significant changes in almost all of the process measures. There were a couple of the metrics where we were performing reasonably well, and one of the metrics, interpartum antibiotics, was introduced relatively late into the pathway. But we also saw a really significant jump up in the percentage of overall in optimisation, either measured by the percentage of interventions given or measured by the percentage of mother-baby dyads that had the entire pathway for which they were eligible. I'm going to pass over to Aless now to talk about some of the quantitative elements and some of the enablers and barriers. Thanks, Aless.
Great, thank you. So next slide, please. You can see here the NNAP data. I believe was this from 2020, Sarah? No, 2021.
Yeah, that that shows looking specifically at cord clamping, whether you want to call it delayed or optimal. The Southwest have been performing, let's say, far better than we were after the implementation of PERIPrem. So another one of those quantitative outcomes. Next slide, please. And getting it right first time has been looking particularly at perinatal optimization as well, in fact, and has mentioned the PERIPrem project in its overall report, showing that perinatal team working can really achieve these outcomes if we all work together and put our minds to it. And a particular quote at the end from Mary is that she strongly supports major improvements in early perinatal care as one of the key ways to reduce neonatal death and significantly reduce brain injury in this population. And PERIPrem is an outstanding example of this ambition, which is, it's not about PERIPrem, it's actually just about any hospital where all the teams work together, everyone works together. And as Sarah said before, that's not just neonatal with obstetric, with midwifery, that is like a midwifery care assistant, staff in the theatre, the trainees you've got rotating around, the SHOs, the regs, this is every single level working together as well to do this, because if you exclude any stakeholder, any group, then you're really missing out on an opportunity and ideas and utter cohesion of that group. Just kind of brings everyone together. Next slide, please. So there is a formal evaluation that we have performed for PERIPrem, looking specifically at the qualitative data. And specifically the barriers that we have found. Obviously, everyone will quote this for anything that happened over that time period. COVID, not ideal. Fortunately, COVID happened whilst we were still in the planning phase of PERIPrem, right at the end of it. So all of a sudden, everything just suddenly went virtual, and all meetings are virtual. But that was a barrier, but it also will come up as an enabler as well, because it enabled people to attend stuff remotely, like here today. This is now, normally it would have been very much an in-person meeting, and if you weren't there, you probably missed out. But being able to accept this is done virtually, and again, it's about cutting down those and reducing those barriers, enabling people to come together and work together and share ideas and collaborate. Time is always a barrier in the NHS, and no surprise that was the same in PERIPrem, but that's partly where the funding was really vital. And going forward, it's really great that perinatal optimization is really getting the importance and the recognition, that it needs in the importance of the baby's health going forward for the rest of their entire life and their survival, just through getting this perinatal 24 hours right. Complexity, because there were 11 elements. It's an incredibly complex project, and most teams started on one kind of easy win or one element where they could probably improve the most before looking at the whole bundle. But different teams did it differently. Some people had different focused groups focusing in on different elements. It's all about looking at your microsystem. And as Sarah said, it is having that person locally who is the spokesperson for the project, who is the champion, who has buy-in from everyone else, and just look at what will work best in your context. The psychological capacity was talking about COVID. There was a huge psychological burden from COVID on everyone, and change is very much an additive psychological burden. And so trying to do all those things at once was a bit challenging, but it's important just to recognise that and have that in your head, that people need a bit of psychological space to be able to adapt to change. Resistance to experimentation was a bit of a challenge, because that in healthcare, we like to know that when we make a change, we're making a change with a positive. So we want very much evidence there, ideally, before we make the change, so that we have no risk involved. And if you're changing a protocol, you change the protocol hopefully just once, and then it'll get changed 3 years later, because that's what happens to every single protocol. But quality improvement happens through experimentation, and having that little bit of flexibility really helps to find out what the ideal path can be. Choice of PERIPrem leads, it was really vital to get the team members right. There was a time limit, obviously, on the teams on when we had to have them implementing by. People who took their time and appointed the right person, right people, right team together, did initially far better than the people who had a lot on their plate and ended up having people go into post who perhaps didn't so much want to be there. So it's really important that people doing this, to be able to win the whole team over, they have to be interested and engaged and not coerced. And each intervention had its own bespoke barriers and enablers, which were far too detailed to go into, because not only did each intervention, but each locality did. And so that is that real importance of deep diving and knowing your own local microsystem. Next slide, please. So the enablers were awareness of and belief in the evidence-based knowledge. And that's what Tracey was saying. Once people realise how much an intervention like, for example, optimal cord clamping can do to reduce mortality, it's stunning. It's stunningly simple, stunningly cheap, and stunningly effective. So making sure that everyone is aware of why they're doing what we're asking them to do, and the fact that it is evidence-based, it really helps. As I said before, funding was a key enabler, because that gave us time, but more time is always going to hopefully, if the right team work together, result in better results. Toolkit and checklists were enablers, because it meant that people didn't have to reinvent the wheel. Everyone didn't have to spend the time creating these, so a lot of time was saved and everyone was on the same page. Co-design with parents was a huge enabler, because we knew then that we were getting it right, that this also mattered to parents, that we were fighting the right fight, and that parents were able to be the voice of the project, because parental stories and the stories of the family's journeys are the strongest thing we have to motivate change, we've found, really, as a result of PERIPrem. I mean, probably knew that before, but it really has been hammered home through PERIPrem. Flexible implementation techniques tailored to local systems, what I've been saying. Choice of PERIPrem leads, yes, it was a barrier and an enabler. Creating teachable moments in busy clinical environments, so that's just being adaptable. We all have to do that clinically anyway, but everyone made it work differently. Tracey did trolley teaching, other groups did work differently. It was more about virtual teaching, and I myself was asked to give teaching on volume targeted ventilation to a local special care unit, because they just didn't have the background knowledge there. And so it was not just as simple as just starting to do it. Coming from someone who used it extensively and could make it and sell it as very much a safe intervention that is quite easy to implement, and teaching it with case studies to the MDT, so from consultants through to trainees, reggers, SHOs, through to the neonatal nurses, so the neonatal sister and the neonatal nurses working on the unit. Everyone attended that session, everyone took part, and as a result, it just made it that little bit more tangible and approachable, and then resulted in implementation. So everyone can help everyone else, in the network. That's collaboration from me as a neonatal grid trainee, speaking to teams who are working in a SCABU. Any type of teamwork works here, whether it's within your neonatal unit, whether it's within your perinatal team, whether it's within your network, or whether it's within your MCQIC. It's everyone working together helps in a different way. Development of that team identity, so knowing who everyone is. Neonatologists perhaps being at the safety briefing in the morning on the labour ward, obstetricians coming to the neonatal unit, not just when there's a problem, just brings everyone together, having a familiar face and good communication. Next slide, please. And looking at the stats, we all love a p-value. Here are some significant p-values for you. There was a statistically significant improvement in team function from qualitative interviews, pre and post PERIPrem implementation. There was improved situation monitoring and improved communication within teams. And that was just to emphasize, PERIPrem did not support, did not aim specifically to provide interventions to develop teams. We were very much looking at quality improvement and the implementation bundle, and the way that we had to work around to achieve that resulted in the positive impact on team working. Next slide, please.
Thank you so much, Aless. And there was so much that was really beneficial in the evaluation. We've popped some links in the chat. Nirmala, I don't know, I apologise that we've slightly run over time. Would you still like to watch the parent video, or would you like to move forward to the Q&A? Entirely happy to be led by you.
No, thank you. That was a beautiful presentation of all the work so far. But yes, we would definitely make time for seeing the video as well, please, Sarah. So I think we will wait for, yeah, there we go. Thank you.
The thought of going into premature labour with twins in a global pandemic was absolutely terrifying, and something that was so scary for me. The fact that I learned about the PERIPrem package and had that available to me made things so much more relaxed, and I knew that I and my boys were going to get the best care possible, and that's something as a first-time mum was just so good to have. From very early on in the pregnancy, we knew that things weren't running smoothly, and we knew that we were going to have a premature delivery at some point. I was lucky enough to receive all 11 elements of the PERIPrem package. PERIPrem made me feel a lot more informed about exactly what was going to happen to my babies. I think before I'd had the conversations that I'd had with members of the PERIPrem team, I was totally naive to the whole aspect of prematurity and how prematurity can impact babies. Because of the PERIPrem package, neither of my boys have had to experience some of the most awful things that can happen to a premature baby. I think the organisation of the PERIPrem package for me was incredible. From the moment I got to Yeovil and they realised that there was a problem, they were talking to me about the PERIPrem package, they were explaining the elements to me, and they were instigating the first part of the package. They were getting me to the right hospital. As soon as they realised things were going the way they were, they got me to have the steroids. As soon as I was told, yes, you are delivering, I was given the magnesium sulfate and everything. I just felt as though everything was sorted, and I went into my cesarean delivery knowing that I'd done everything that I needed to do beforehand. The consultant at Swindon, Sarah, would often ask, how do you think the boys are doing? And it was so lovely to actually be asked that, because sometimes you can kind of feel quite like you're not involved, you're not the parent, and it definitely made me feel more as though actually, you know, I'm an essential part of my baby's care, rather than just sitting at the side of the incubator feeling helpless.
It's incredibly powerful hearing Lauren's story, and I think it really demonstrates how vital PERIPrem has been for some of the parents, but also how important parents have been in the co-production of PERIPrem. Parents with lived experience of preterm birth have really driven this project forward, really helping us develop things like the parent passport, which has been so highly valued by parents whose babies have received the benefits of PERIPrem. I think the partnership between clinical teams on the front line, perinatal teams across the Southwest, working alongside parents to really deliver the quality improvement, has been one of the key elements that's really made PERIPrem so successful.
I think the fact that PERIPrem has been rolled out during a global pandemic is just absolutely incredible. The NHS have already got so much pressure on them to ensure care, you know, across the country for other things, that the fact that there are still a group of people who are prioritising the care of babies who are born prematurely or are born sick is really amazing to hear. I'm so lucky that I received the care that I did. I will be eternally grateful to all of the team that worked with me during the delivery of my boys and the care that they received afterwards. I truly believe that this package saved my boys' lives, and without it, I'm not quite sure where we would be now. But because of PERIPrem, I have two 17-week-old beautiful little boys who are just starting to smile, and that is down to PERIPrem.
It never fails to be so powerful. I always really enjoy that. Thank you so much for having us here today to talk to talk about PERIPrem. And Nirmala, I think we're opening for panel questions. Thank you so much.
Yeah, thank you so much. It was absolutely a touching video and a fabulous presentation of all the work that you've been doing in the southwest of England. And it just highlights the importance of teamwork and building relationships in, you know, a complex healthcare system. So thanks a lot for taking the time to come and speak to us. So I would like to invite Julie-Clare as well back, and of course Sarah and Aless to stay on. So we would look out for any questions. So if anyone has questions, please raise your hand, or you could pop it in the chat box. But you can all see the fabulous comments we have in the chat about such a powerful video and great work that you have done. So maybe I will start off with a question just to give time for everyone else to come in. How did the regionalization of the work start? You know, you started locally, and I think it works really well when you're already a team and then you build that network. But it's about how did you actually then, you know, what measures did you take to spread it?
Thank you, Nirmala. Really good question. So that was really supported by the Academic Health Sciences Network. So both of them have a really strong track record in delivering things like the Precept programme, which originated in the Southwest for magnesium. And they had an evidence into practice challenge wanting to spread projects, and we put the small project from Swindon forward, just as Karen was doing similar in Bristol. So we then worked really closely with the network all the way along. So this was very much delivered with the network for the network, but it was led separately to the network because it takes a huge amount of focus and time to do that. And we contacted each of the centres in our region and started to recruit those people, the quad team, the obstetrician, the neonatologist, the nurse and the midwife. And then as the operational clinical lead, I started meeting with each of the teams with some QI coaching support. We looked at their data together, and often I didn't necessarily lead the meeting with them. I just facilitated them coming together to talk about their what they were doing and what they were working on. And then we would catch up every 6 to 8 weeks via Teams. Aless did a lot of work dipping in and out for individual coaching with the units as well, specifically, as she said, around volume guided ventilation, but a number of other things as well. And then it became a much wider collaborative. We had share and learn sessions with all 12 teams joining together. And then you just start to see the email traffic fly. So one of the midwife colleagues who works with Janice, who I can see is on the call from one of the small units in the northern part of Devon, starts to advise one of the NICU midwives on how to get different tubing to support delayed cord clamping. And just it became a very, very powerful perinatal collaborative.
Thanks a lot. That was really helpful. Definitely things we could take forwards. Are there any questions at all? I think everyone's stunned and emotional. We have Leslie Jackson. Thanks, Leslie.
Thank you, everyone. Just an absolutely amazing set of presentations. Absolutely wonderful. I suppose mine isn't so much a question. I guess it's just, the obvious statement. Team Scotland, Team Perinatal Scotland. How are we going to get this going, guys? And how are we going to do it soon?
Great. Yeah, I think that's why the webinar is happening, and you know, as Julie-Clare and Sarah have said, the work kind of originated in Scotland, and of course, you know, some work is happening, and we have Lynsey actually as the next speaker to kind of answer that question for you. But I'll just let Julie-Clare speak. Is that okay?
I think this is really crucial, and you know, we've been trying to deliver the perinatal wellbeing package with varying success really for some years now. To me, I think the key thing is for us at local level to be establishing teams, perinatal teams that involve midwives, obstetricians, neonatologists, neonatal nurses, anaesthetists at a minimum, and looking at our data together, establishing the shared goals. And I think because it is sat within the neonatal programme, the perinatal wellbeing package, that has probably disadvantaged the concept of perinatal team working. And I think if we can get over that and start seeing it as a joint shared goal, that's the way forward. We're starting that in Edinburgh. We've got a perinatal optimisation team starting. It has taken us quite some years to get round to doing that, but I think already we've got parents who are also keen to be contributing to that, and so there's a feeling of momentum happening, and we're looking at data together and sharing our results across the team, and I'm hoping that will be helpful.
Thank you. Do we have any other? So we have a comment from Jacqueline Welsh. We have a perinatal optimization group in A&E, Ayrshire and Arran, and we need to go through preterm measures which work, but would love to know more about the passport. So Angela,
It's more a comment. Thank you for the presentation. It's absolutely inspiring, and thank you for acknowledging that some of the work came out of Scotland. But I think now that you have taken it to a completely different level, and we're now learning from you, which is what our programmes are all about, all share, all learn. And I think today's webinar is very much a call to action for all of the units across Scotland and all of the multidisciplinary team to say that this is a must. And I do think we are at that tipping point now of saying we are a perinatal team, not a maternity team, not a neonatal team. We are right down the middle of perinatal, and I think we all have a role, everybody on this call, but everybody in the unit and everybody across Scotland, to start moving this forward. So just thank you, inspiring. Thank you very much.
Thanks, Angela. Julie-Clare, was that an old hand or a new hand? No. Okay, so I think we are kind of running out of time. So I will thanks a lot for all your presentations today. Absolutely inspirational. So moving forwards to answer how we are proceeding, our first steps are obviously building these perinatal teams, and Lynsey Still will talk to us more about future activities.
Thanks, Nirmala. Just checking everyone can see my slides. Give me a thumbs up. That'd be okay. Thank you.
Yes.
So for those who don't know me, my name is Lynsey Still. I'm a neonatologist in Glasgow, and I'm the quick neonatal clinical lead, and have real passion for perinatal optimisation. So I'm just going to kind of hopefully bring it full circle, pulling together all of the kind of ideas after the exceptional presentations we've had, and I think we're all feeling that real kind of motivation after today's presentation. So we're all here because of all of this fantastic work that's been going on. It's a key priority within our services. And as we come into the landscape of a huge amount of scrutiny in perinatal services, we need to kind of keep this focus and this momentum going. And throughout the past few years, we have looked at various amounts of data for all the different measures, and you'll hopefully know these run charts locally. But these are the overall compliance run charts that we pulled together locally, and we've actually combined this into aggregated data Scotland-wide. And the top left chart is looking at, for every baby in Scotland, how many of them have actually achieved all of the elements of the parental wellbeing package relevant to their gestation. So you can see that even though we've had this programme in place since, I think it was 2017, the wellbeing package, and then the poster came in late 2019, even though we've had that in place, our median hasn't really changed, and we've had spikes of kind of general higher, but with no real definite shifts up. However, kind of more recently, we'd hope to see a little bit more of a shift in data. So that really highlights the fact that we've still got a way to go. And sadly, we can have babies that are given many of the interventions, but often there's the same ones that pull us down, which are typically optimally timed steroids. They have it, but they've often had it more than a week before. Or, for example, one of the areas we do perform particularly poorly in is the maternal breast milk. And I think there's problems across the country. The bottom right chart is the element compliance. So that's of all of the elements that could have been delivered in a monthly period. We have had a small increase from a medium of 74 to 77%. So while there are some trends in the right direction, we've definitely got a way to go. And I think this brings us to the critical point of we have done some of the work, but we've got a huge kind of mountain to climb before we get to the where we need to be. So we've brought in the package, we've brought in the poster and the education behind it, but MCQIC are really seeing a real need to change their focus and move away from just data collection to actually supporting their QI efforts. So as the programme evolves over time, regardless of what the aims and measures may kind of evolve into, perinatal optimisation will absolutely remain a key focus. And that's particularly with the background of we've had previous spikes in neonatal mortality, and the majority of these babies are within that preterm category. And with the learning that we've seen locally from preterm bundle, particularly within Glasgow, we've got the PERIPrem, the fantastic work. We really saw the need for a national tool to support our perinatal teams and deliver improved perinatal optimisation. And this is really built on the essentials of safe care that we've referred to quite a few times today. And that is our real drive to create high quality, consistent and very safe clinical care processes that are reliably delivered for every patient and for every preterm baby. So our preterm passport, we've seen the PERIPrem passport is absolutely beautiful. And we're pulling on that learning to not just provide a tool and somewhere to write things down. We're trying to enhance communication. We're trying to improve the collaboration and build our perinatal teams, and at the same time delivering a standard of care, the gold standard of care that every preterm baby has the right to achieve. At the end of the day, every baby deserves the best possible chance of survival and the best possible chance of a good outcome, and that is purely and very not purely, but very reliant on optimisation both antenatally and postnatally. So the passport is pulling in the antenatal optimisation measures, but has a real focus on the communication side of things, the team preparation, and building a pause into the delivery so that all of the shared goals are communicated clearly between our teams. And I think that was really nicely demonstrated today with the various presentations, and for example, Tracey going in and double checking that the babies had their prophylactic hydrocortisone. So everyone is taking ownership and a real passion project behind it to make sure these babies have the best possible chance. And that, as I said, that's pulling in the postnatal optimisation as measures. So I'm going to share with you our first draft of our Scotland-wide preterm passport, pulling together all of these. So just important to highlight, this is the first draft, and we're still working on colours and design, but I just wanted to take this opportunity to show this. We are envisaging this as a paper pathway similar to PERIPrem for every mum and baby that is delivering less than 34 weeks. And we're really trying to highlight the kind of journey that women go through from antenatal, maternity, into labour ward and right through into the preparation, the delivery room, and into the postnatal team. So it's building in place of birth, steroids, magnesium and antibiotics, as would always be the case. And then moving on to ensuring the counselling and the discussions have been had, the preparation of the team, the perinatal stabilisation and management, and then the postnatal aspects as well. And really trying to flag up other areas of team working, like having a pause before the delivery and a pause after the delivery on admission to NICU, where teams can really focus on the allocation of tasks, responsibilities, and again, the shared goals that we have to have at that point of rapid access, drugs, administration of fluids, and minimal handling to avoid secondary hypothermia. And it's about the whole team sharing and agreeing and envisaging these goals that we all have to take responsibility for. So in terms of the next steps, what we're going to do with the passport is we're still tweaking it at the moment, and we're looking for some more feedback between of the multidisciplinary teams. So hopefully our final draft will be ratified before the end of the year. And in the early 2023, we are going to move to test the pathway in units along the pathway. So we're going to look at testing in a SCBU, an LNU, and a NICU within a specific area to try and see the transition of the pathway from antenatal, neonatal into postnatal care. And we hope that this will be a really fantastic tool to be able to pull teams together to see that there's shared ownership of all of this work and move away from where it has sat within the neonatal programme. We also are very aware of the impact of data, but making data visual. And although we have the run charts and the fantastic toolkits that have been built for us for some time now, there is a bit of a breakdown in terms of communicating that data to our frontline teams and making sure that they can visualise it. Run charts don't communicate to all people particularly well, so we're working similar to the PERIPrem dashboard to see if we can try and create more visual representation of our data, which can more accurately kind of communicate with our teams. So watch this space for development of the toolkits and creation of that more visual reporting tools that can provide more of an instant feedback to our teams. So we're very excited to take these next steps forward. And as I said, it's at that critical point where this work is needing to get taken to the next level. And I'm going to hand back to Nirmala, where she'll pull it all together and we'll talk about the next steps for MCQIC and then the next steps for you within our clinical communities. Thank you so much.
Thanks, Lynsey. It has been a fascinating morning, and thank you once again to all the presenters. We have the scan code for evaluation, so I would be grateful if all attendees are able to scan and provide us feedback so we can use that to improve our work going ahead in terms of webinars or quick work. We would really value your feedback in how you see us going forwards with this. We have our contact team. You're aware we're all on this call. So Lynsey, sorry, I forgot to introduce you as we were running a bit late, but Lynsey, neonatal lead for SPSP, Angela Cunningham, midwifery lead for SPSP, and we have Joe Thompson, Damien, our improvement advisors, guiding us and taking us along, and of course the whole team who's present today. So we're looking at our next steps as continuing to promote the perinatal collaboration across maternity and neonatal communities. As Lynsey showed the perinatal passport resource, we are very keen to test this out in one region, hopefully, so we can get feedback and improve it before we plan for a final rollout. And we want to continue to develop our improvement offers for the perinatal and pediatric programs of work. And as already alluded to in all the talks, we want to embed the essentials of safe care, of providing patient-centered care, improving leadership, and providing resources. I would like to thank one final time all the presenters and the speakers for their valuable presentations, thought-provoking. And we would want to thank all the attendees. And now it's over to you as a team to optimize the care for all the mums and the babies we look after. Thank you once again, and please do fill in the evaluation form.